स्विच टू
हाँ
गैलरी
हाँ
व्यू।
हाँ, बस बस स्विच टू गैलरी व्यू है ना। इसमें अब
हाँ,
तुमने डाउनलोड करा हुआ होगा, तो डाउनलोड में जाओ और उस इमेज को क्लिक कर दो। लास्ट अभी जो 2 मई की इमेज होगी ना।
करी थी मैंने, अभी पता नहीं कहाँ चली गई
नहीं
है।
नहीं, ये तुम्हारा जो पीसी है ना, जो टैबलेट में सेव हो रहा होगा
हाँ,
सारा, डाउनलोड्स में जाओ, डाउनलोड्स में मिल जाएगा। मैंने भी ऐसे ही करा है, बात करते करते मैंने कहा ट्राई करो, नहीं तो ऐसे ही चलेगा।
कोई बात नहीं, हो गया तो ठीक है, अदरवाइज
जैसे ब्लर माय बैकग्राउंड आता
गैलरी।
है।
नहीं, आ गया वो तो, गैलरी में तो आ गया, ये
We
डाउनलोड्स में
are
आ
we
गया।
are live
माउस
now. We are
सेट
live
ऐसे
now.
व्हाट्सएप
ओके सर।
Bhavna, we are live now.
ओके सर।
ओके।
Okay. Okay. So good evening, friends. I am Dr. Harivansh Chopra, and I welcome you all on this unique concept of World Health Day celebration. And the theme of World Health Day, as all of you know, is healthy beginning for hopeful futures. Rather, I say it should be happy futures also, because if the beginning is good, then future is hopeful as well as happy. So this time we categorize the competition into three categories. That is the young professional below the age of 40 years. That is one category. The second category is the postgraduates, and the third category is undergraduates. And we are extremely thankful to all our sponsors, which you can see in the background, who have given their concurrence for sponsoring books to the top seven presenters in each category. So, and in today's presentation, we have top 10 faculty or top 10 professionals from various colleges across India who will be presenting their PowerPoint on one or the other related themes to mother and child. I will not go into the detail, but I will also like to welcome my two more judges, Professor Dr. Seema Jain, who is Professor and ex-HOD of Community Medicine, LLRM Medical College, Meerut, as well as she is the ex-president of IAPSM UP UK chapter. I would also like to welcome Dr. Bhavna Pant, who is
नमस्कार।
also professor and HOD of NCR Medical College, and she is the current president of IAPSM UP UK chapter. Incidentally, I am also the ex-president of UP UK IAPSM chapter as well as ex-national president. So I will not waste any more time in giving the introductions, and I give best of luck to all the participants, and let us start our competition on this particular theme, because the idea of the theme is that this theme has to be celebrated throughout the year. So this is our little effort to generate awareness in the mind of the people, as well as stimulate the young faculty what they can do or what they are doing. They'll be sharing their innovative ideas, research, and their thinking, that how we can make the life of every mother and child a good, splendid, and wonderful way. How they can proceed further without any complication and can keep reach to the highest potential of their health. So, with this, I will like to invite our first participant, Dr. Abhishek Kumar. Abhishek, you can start sharing your screen and then you can start your presentation. Over to you, Abhishek. The total screen is yours.
Good evening, everyone. Thank you, sir, for this opportunity, and good evening, honorable judges and all the participants. I will be sharing the screen and soon start the presentation. Is my screen slides on slideshow mode? PPT on slideshow mode?
Yes, yes.
Okay. So, In this competition on World Health Day PPT competition organized by Chopra sir, I will be covering the programs related to reduce the maternal mortality. So I am Dr. Abhishek Kumar, working as Associate Professor in Department of Community Medicine at Manipal Tata Medical College, a branch campus of Mahe Manipal at Jamshedpur in Jharkhand, and also the Joint Secretary of IAPSM Jharkhand chapter. With this background, I will be starting my presentation as the following learning objectives. Commitments for SDG 2030 related to maternal health in India will describe the components of Janani Suraksha Yojana, components under JSSK, Janani Sishu Suraksha Karikram. Will be listing the components under Pradhan Mantri Surakshit Matrit Abhiyan. Mention the components of Surakshit Matrit Aswasan, mentioning the component of Laksh, and will end with mentioning the components of mother's absolute affection. So, according to National Health Policy 2017 and SDG commitment for RM and CHA, maternal mortality ratio, the target is to reach 70 per lakh live birth by 2025, neonatal mortality 16 per thousand live birth by 2025, and under 5 mortality by 23 in 2025. So India is on track to achieve these goals related to the health target 3 in SDG, and the MMR has reduced to 70 per lakh live birth and under 5 to 25,000 per thousand live birth. What is the goal of this all program? To end the maternal and neonatal death and to achieve zero maternal newborn deaths through quality care with dignity and respect. We can see this trend of MMR in India. It has started 130 per lakh live birth in 2014-16, which has come down to 1997 and 2018-20, according to the Special Bulletin on Maternal Mortality 2018-20. So why this maternal mortality happens? So going behind, we can find the 3 delay model to the maternal death, which can be prevented. The 3 delays are delays in seeking care, delay in reaching care, and delay in receiving the quality care. So it is high time to identify the need to seek care, to reach facilities in time, and after reaching to receive quality care at facilities. So moving ahead, various program we will be discussing under headings of Janani Suraksha Yojana. It is a cash incentive program which promotes institutional delivery for pregnant women going to deliver in public health institution. Once this program has been launched, the percentage of institutional delivery in India has risen sharply from 47% in 2007-8 to 79% in 2015-16, and the number of beneficiaries has also gone from lakhs to crores in last few financial year. So we can see the incentive under JSY to ASA and beneficiary under this program. When it comes to the low performing state, in rural area, the mother package is 1400 and ASA is package is 600, while in urban area it is 1000 and 400 for mother and ASA respectively. In high performing state, rural area, mother package is 700 and ASA's package is 600, while in urban area it is 600 and 400 for mother and ASA respectively. Coming to the next component, Janani Sishu Suraksha Karikram. It is also a program to promote institutional delivery, which provides cashless delivery. The earlier was cash benefit, cash incentive, but it is cashless. And what is cashless? Delivery, drug, diagnostic, transport, consumable, blood, and transportation. So this is also going to promote the institutional delivery. The following services are available: cashless delivery both for normal and cesarean section, drugs and diagnostic, diet for 3 days in case of normal delivery and 7 days for cesarean section, blood whenever required, transport from home to health institutions, transport between facilities in case of referral, and drop back from institution to home after 48 hours of stay. These all are the services which are covered under JSSK, which is a cashless delivery program promoting institutional delivery. Now coming to Mother's Absolute Affection, it is a nationwide program organized by Ministry of Health and Family Welfare, Government of India. It aims to promote breastfeeding, early initiation of breastfeeding within an hour of birth, and exclusive breastfeeding for first 6 months, and also there is a provision of counseling services for supporting breastfeeding through health system. All the state and union territory is covered under this program. We can see the components it provides. It aims to provide enabling environment and demand generation through mass media and community. It also aims to organize community level activities which promote breastfeeding, capacity building of healthcare provided at all delivery point and lactation support services, and certain institutes are being recognized and awarded also for best performing baby friendly facilities available. And we at Manipal in our urban health training center being the in charge, I have also initiated this uh, breastfeeding initiative in a small level, and slowly we are growing. Now coming to Pradhan Mantri Swachhit Matritva Abhiyan, and it is a program which in which 9th of every month is dedicated to pregnant women's health, and I pledge for 9 is the tagline for this program. In this program, following services are available: antenatal checkup for pregnant women in second and third trimester, improve the quality of care during antenatal visits, appropriate birth planning and complication readiness, identification and line listing of high risk pregnancy based on medical history, emphasis on early diagnosis, appropriate management of women with malnutrition. In this program, obs-gynae radiologists, physicians from private sector are also encouraged to provide services at public health facilities voluntarily. Mother and child protection cards are also provided, and they are considered as safe motherhood booklets. A sticker is a indication of the risk of factor for the pregnancy. Green sticker is for women with no risk factor, and red sticker is women with high risk pregnancy. And we are also implemented these programs at our USTC on 9th of every month. Next is Pradhan Mantri Matru Vandana Yojana. It is also a program to not only to promote institutional delivery, to also to promote the pregnancy registration and MCP card registration, and also the immunization of the child, in which a pregnant woman or lactating mother gets up to 6,000 rupees as incentive in 3 installments. First installment, 1,000 rupees, is given when the registration of pregnancy with the MCP card documentation is done within 150 days of last menstrual period. Second installment of rupees 2,000, which is given after completion of at least one antenatal checkup, and it can be claimed in post 180 days of pregnancy. Third installment is childbirth, when the childbirth is registered and child has received the first cycle of immunization, BCG, OPV, DPT, and hepatitis B. And Aadhaar is mandatory for the registration, and the third installment is rupees 2,000. Next is Surakshit Matritva Aswasan, and the beneficiaries of this scheme are
Sir,
all
you are
pregnant
done with
women.
8 minutes.
Thank you. Should I complete or?
Yeah.
Two
You
more
have two
minutes.
minutes more.
Okay. Okay. All mothers up to 6 months post delivery and all sick newborn. The objectives are zero tolerance for denial of services, integration of all the previous scheme, 100% maternal death reporting, free checkup for pregnant women, free transport, zero dose vaccination, and direct cash transfer. Next is that as a labor room quality initiative, which is a M Health tool to improve the training, post training reinforcement, mentoring, documentation, demonstration. All the district and sub district level with medical colleges are registered, and it aims to provide quality certification of labor room and incentivize for achieving the target. And last not the least, Kilkari, a baby gurgle app which delivers 72 weekly free time appropriate audio message about pregnancy, childbirth, and child care directed to the mobile phone of the family, which is a duration of 1 minute. Thank you, and that's all from my side.
9
Thank
minutes, sir.
you. Thank you, Dr. Abhishek,
Thank
uh,
you, sir.
for enumerating all the schemes related to mother health as well as the neonatal health in our country. Now, over to Dr. Seema.
Thank you, Dr. Abhishek, for such a. I could see your slides were very focused and very elaborated messages were there. And it was a clean template. And I wish you all the best. Good presentation.
Thank you. Thank you, ma'am.
Thank you, Dr. Seema. Now, before I go to Dr. Bhavna for her comments, I will request the next speaker, Dr. Daraksha, to kindly start sharing your scheme so that we can save some time. And over to you, Dr. Bhavna.
So the presentation is very nice and it is included all the programs of the. Hello.
Yeah. It is going on.
The
Please
voice is
continue.
good. I think presentation is very good, sir, and it is complete presentation from starting of 2004 to up to I think the latest program has been included in this. Hello. I'm audible,
Thank you,
sir?
ma'am. Yes,
Yeah.
ma'am.
You are audible. You are audible. You are audible. So anything else you want to add to? You can add. Otherwise, we can go to the next speaker then.
It is fine, sir. Next speak.
Okay. Okay. So now I'll request Dr. Daraksha to kindly present your PPT and the screen is all yours. Dr. Daraksha, please. Dr. Daraksha, you are not audible, Dr. Daraksha. Nor you are on slideshow. So if you have some problem,
There is some problem because unmute तो है ये पर इनका वीडियो भी कुछ issue आ रहा है.
so Dr. Daraksha, are you able to? If you are not, then we'll go to the next one. Then kindly stop sharing your screen, Dr. Daraksha. You can come next.
Yeah.
And we'll go to Dr. Deepti Shivankar. Dr. Deepti, can you please share your screen?
Yes, sir. I'm on it. Sir, is my presentation on slideshow mode?
Yeah, absolutely. Dr.
Oh.
Sara, kindly start the timing.
Good evening, all. Myself, Dr. Deepti Shivankar, Assistant Professor, BAVMC Pune. Through this presentation, I want to share my perspective and raise the question, if we as clinicians, policymakers, and authors failing to keep the gender norms aside and not talking about the paternal involvement in child healthcare. So basically, gender norms are the unwritten informal rules or expectations from individuals of certain gender. And henceforth in the presentation, I'll be just using PI as short form for paternal involvement and CH for child healthcare. So it is deep rooted in our culture that children's health is the responsibility of their mothers. 93% of all rigorously evaluated parenting interventions worldwide are which are targeting 0 to 3 year olds have exclusively focused on mothers without any attention to fathers. In high income countries, the role of fathers has been changing. In 1985, which was traditionally a provider role, which has changed in the present to a greater involvement in family well-being and the child rearing. So this has also been seen in India in certain households. So this is just my funny take on how India's national health programs and policy makers mainly focusing on mother for improving child's health. So this is a compilation of certain research articles outside of India, where it has been proven that what is the impact of paternal involvement in child healthcare on child's health. So in the first article, where there was more frequent visits of father to the hospitalized preterm infant, it was associated with higher infant gain. In the second article by Vaisoki and Gavin, the greater direct paternal involvement in management of the chronic health conditions like asthma and type 1 diabetes mellitus, greater treatment adherence and overall quality of life was seen. In another article, it was found that greater father involvement is associated with better social, emotional, physical, that is the holistic health of the children. So the first one is my favorite statement by the UNICEF, that fathers are one of the best yet most underutilized child development resources. Like the UN Convention on Child Rights said, it is a child's right to receive responsible parenting from both the parents. Fathers are important stakeholders in the promotion of maternal and child health. So it is a no-brainer that paternal involvement in child health care is beneficial to the child in numerous ways. So let's look at it. Gender Inequality Index developed by United Nations Development Program, where India ranks 108 in the list of 193 countries. While we are considering three different dimensions in the GII, let's focus on labor market dimension, and under that, labor force participation rate indicator. So under that, the labor force participation rate in females was seen to be just 28.3. That is, out of all the 15 years old and older female, only 28.3 females were working and they were getting paid for that, while the same indicator for the males was 76.1%. When we consider the global gender gap index, where zero is the where there is absolute inequality and one is where the gender gap has been removed, we can see that India ranks at 129. And if we consider all the four dimensions, here is better shown in this zoom figure, we are doing quite fine in health and education. But if you look at politics and economy, we are, even in case of economy, even we are below the global average. So, in the female labor utilization in India report by Ministry of Labor and Employment, we can see that the labor force participation rate in rural female was 36.6%. In urban female, it was 23.8%, whereas in context of Indian females, it was 32.8%. If we look at the commonest reason why there is less involvement of females in labor force, we can see that 44.5% in 45.5 females, the reason was it was either childcare or personal commitments in homemaking. Also, according to one UK-based study, the probability of mothers resuming employment was found to be increased if the father is more involved in childcare. So, it is well established in multiple studies outside of India that paternal involvement in child health care is significant in improving child health as well as female employment. We can look at it that where in a study where interventions aimed at improving mothers and fathers' perspective on attitudes about childcare and significance of shared childcare responsibilities, it was seen that it promotes fathers' involvements in childcare. So it's not just important to change the perspectives and attitudes of fathers, it is also important to change the perspectives of females or mothers, because they themselves in many cases think that it is primarily their responsibility to take care of a child. So even though there has been a lot of evidence outside of India, but the evidence of impact hasn't been translated at all to the improved implementation. So if we look at India, there is a significantly lack of research in India in case of paternal impact of child, paternal involvement in child health care on child's health and its impact on maternal health as well. There is no quantification of how much paternal involvement is there in child health care. Secondly, there is lack of research in impact of paternal involvement and child health on mothers' labor force participation. So because of these two, there is also a lack of research in design implementation of interventions targeting paternal involvement in child health care. So research in these areas might help us gather the evidence and the conviction to bring out the systemic reform by involving fathers in child health care principles. So let's connect the dots, and I want to summarize my perspective. So paternal involvement in child health care improves child health, female employment, and family health. There is no or little mention of father's role in child health in most of the standard books of community medicine. I don't want to comment on books about pediatrics or OBGYN. There is need of research to establish evidence of impact of paternal involvement in child health. There is a need to encourage ideation, implementation, and study of impact of interventions improving paternal involvement in child health care. And I think we need to examine ourselves to see if we ourselves carry social bias, gender norms in our minds and our advice to the patients and the community. Times are changing, society is changing. I want to ask if are we also changing with it? And I feel the initiating conversation is very important. So These are my references, and that is all from my side. Thank you all
Thank,
for listening.
thank you, Dr. Deepti, for bringing out an important aspect of paternal involvement in child health care. And recently, when I was attending this World Health Summit, there was a roundtable on IYCF, and there was a passionate uh, speaker there who was talking about the involvement of father in the child health care. And this point was also raised that if we want the father involvement to be there, especially in the early phase of a newborn child, then we need to provide some kind of a paternity leave. And of course, this will be for the organized sector, and for the unorganized sector, again, even the maternity leave is not provided. So these are the various issues which are very, very important. And I am happy that you have brought out one more perspective. And if people start working on it, definitely the involvement of the fathers can be further improved. Of course, the father's involvement is always there because they are the decision makers. One has to understand, we have not been able to document it. That is a separate issue, but yes, documentation is also required, because in decision making it is not only the mother which always decide, it is also the father which decides. And of course, if you want to promote the basic interventions which are important, right, which are based on the primary prevention like breastfeeding, immunization, growth monitoring, etc., right, then if the father is involved in all these activities, I think it will go a long, long way in improving the status of all these interventions. So these are my comments and a wonderful presentation. Over to Dr. Seema.
Yes, sir. Again, I'm just similar to you. I wanted to say that it was a very good topic and a scope for research in community medicine. And especially, I would like to especially comment on the your engaging tone of voice. It was the messages were so clear, and also I could see that your PPTs were very virgin. It was that your it is your I think it's your completely brainchild. So I really comment on that. Thank you so much.
Thank you, ma'am. Thanks a lot.
Dr. Bhavna, and I'll request Dr. Darakshan to kindly start sharing your screen. Dr.
Uh,
Bhavna, over to you.
okay, Dr. Deepti, I like your topic of presentation. I think it is very innovative. Not innovative, but it is a burning topic of for the new topic in the research. I think it will be a good topic for the research and future for the researchers. Why the fathers are not um, hello, hello.
Yeah, you are audible. You continue, please.
I am audible. Sir,
Yes,
ये है
Yeah.
कि the fathers का role they have मतलब इतना they are not involved in such type of activities. Those are mentioned in the presentation. Okay,
Yeah.
all the best.
yes. Thank you, ma'am. Thanks so
Thank
much.
you.
Thank you, sir. Thank you, sir.
Thank you. Thank you, Deepti, for highlighting the importance of carrying out the research in the involvement of father or paternal involvement in child health. And now I'll request Dr. Daraksha to kindly give your presentation. And
Sir,
the total
am I
screen
audible,
is
sir?
yours. Yeah, you are audible. And you are on
Okay.
slideshow.
Thank you, sir. Good evening, everyone. I am Dr. Daraksha from the Department of Community Medicine, Government Medical College, Baramulla. And today I'm going to present a presentation on adolescent health, a priority. Now,
Daraksha, your
WHO
video is
defines.
not available. Dr. Daraksha, your video is not available.
So
You are
actually,
not
I'm
available.
presenting from my phone. I'm presenting from my
Okay,
phone,
okay,
so
okay,
maybe that's.
okay. Fine. Then continue.
WHO defines adolescence as the segment of life between 10 to 19 years of age. And the word adolescere, it means to grow or to mature. This period of adolescence is a period of identity and role confusion for the adolescents, as there's a transition from childhood to adulthood and dependence to relative independence. So, why should we invest in adolescents? There are various rationales that have been advocated for investment in adolescents. One is the demographic rationale because their sheer number makes them important not only in India but around the world. Then public health rationale because they are significant contributors to the global burden of disease and mortality. Then when we invest in adolescents, it brings back a triple dividend in the form of their health now, their health as future adults, and their females As future mothers, they bring up healthier generations. And then, like any other human being, adolescents have a right to health that needs to be protected. Now, the issues among adolescents, they are very unique because this age group I said is a growing and a transition period. They're very unique. Like there may be academic pressures, there may be positive and negative peer pressures, there are family issues and adjustment with the family issues. Then there's a issue of self image and esteem, which may be low or high. Then, because they are trying to find partners in this age and their tendency towards experimentation, there are again issues of gender and sexuality. And others include substance abuse, bullying, juvenile delinquency, child labor, child abuse, and trafficking. The health problems of adolescents, other than these issues, they are varied, and because there's also clustering of problems among these adolescents. These include nutritional problems, mental health problems, reproductive health problems, especially in females, like menstruation related problems and problems related to reproductive tract infections. Then substance abuse, endemic diseases, accidents and violence, and non-communicable diseases are on a rise among adolescents. Now, world over, if we see in the high income countries, non-communicable diseases and unintentional injuries make the chunk of the health problems among adolescents, while in countries like India, communicable disease and mental health issues like self-harm. In India, we have seen that self-harm, accidents, and communicable diseases are the most common issues among adolescents. These are the few surveys that I have been a part of that we did among adolescents in Kashmir. I'm going to very briefly share our results. This was a study done among the school-going adolescent girls of Kashmir with special focus on anemia. And it was seen that 53.3% of these girls were anemic, 35% were thin, and 7.2% were overweight. Among the same section of the participants, we saw that 54.9% had menstruation-related problems, among which most common was dysmenorrhea, and 45.3% has symptoms suggestive of reproductive tract infections, of which the most common was abnormal or excessive vaginal discharge. This study was done among adolescent orphans in Kashmir, and it was seen that 38% of the adolescents living in these orphanages had one or other type of psychiatric morbidity when assessed using the child behavioral checklist and mini mental status examination. 23.75% had depression, while 21.4% suffered from anxiety. This study was done among nursing college students, and it was seen that 60% had menstruation related problems, 51.3% were anemic, 50.9% were thin, and 7.7% had risk of developing stress related illnesses. This study again was done among school-going adolescents, and it was seen that 5.8% of adolescents were current tobacco abusers, and 74.1% among these were males. This was a recent survey done among schools for behavioral risk factors among adolescents. And we saw that 39% of the study participants were underweight, 44% were overweight, and 1% were obese. When we assessed their dietary behavior, it was seen that 45% of them resorted to diet restriction, and 32.9% had taken fast food in the last week. And only 50% of them used to carry a lunch pack from home. Regarding mental health, 50% of the students said that they sometimes felt lonely, 43% said that they sometimes had disturbed sleep, and 8.8% of them said that they have had suicidal thoughts in the last 12 months. Physical activity, 51.5% of the adolescents were physically active as per guidelines. 70% had a screen time of less than 3 hours per day, and about 30% had a screen time of more than 3 hours per day. 36.5% of the adolescents reported that there was no slot for physical activity in the school timetable. 3.9% of the adolescents had ever smoked cigarettes. 3.9% had ever consumed alcohol, which is very unlikely in our setting. And 1.8% had ever used drugs. And all these forms of substance abuse were seen more commonly among males. 28.3% of them had been physically attacked in the last 12 months within the school premises. 25.6% indulged in a physical fight in the last 12 months, and 12.5% reported having been bullied in the school during the past 30 days. Regarding sex education, Only 8.5% and 9.1% of the adolescents had received some form of sex education at home and at school, respectively. And education on menstrual hygiene, only 34.5% and 16.3% of the girls had had some kind of education on menstrual hygiene at home and at school, respectively. So these were some of the recommendations that we forwarded to the school authorities and the Directorate of Board, the Directorate of School Education, based on our findings. Physical activity should be made compulsory in the schools. Sale of junk food in the school canteens should be discouraged. Making teaching curriculum student friendly and less stressful. There should be interventions to prevent substance abuse, and introduction of life skills education in the school curriculum must be made compulsory. I would conclude by quoting Virginia Satir, who says adolescents are not monsters. They're just people trying to learn how to make it among adults in the world who probably are not so sure themselves. Thank you.
Thank you. Thank you, Dr. Daraksha. Your presentation reminded me of my presentation, which was done as a part of the WHO panel on adolescent health, and I was presenting overview of adolescent health way back, I think in 2005 or 6 in PGI Chandigarh conference, where I innovated that the problem of adolescent are there in the word adolescent itself, and I made it an acronym, and I made the solutions also from the acronym of adolescent. If all of you are interested, you can search it on net. You may find that presentation somewhere. But yes, it's a good presentation. And of course, the problems of adolescents are there. People are trying to say put adolescent friendly centers, but I don't think they have taken it taken up very well in the community because of the timing and other factors. So these are my comments on it. And yes, over to you, Dr. Seema.
Yes, sir. Very, very well made presentation. And first of all, I would like to congratulate you that you said I mean, like, I'm not aware of that you have hyper write up the main points. That was very nice. That
Thank you, ma'am.
the consistency of color, एक पूरा सारे presentation में वो था. It was so good.
Thank
And,
you.
bullet points, I really like that.
Thank you
Good
so much, ma'am.
presentation.
Thank you. Thanks a lot, ma'am.
So, Dr. Daraksha, kindly stop sharing your screen, and I'll
Okay.
go to Dr. Bhavna. And before I go to Dr. Bhavna, then I will request Dr. Glory Tawaklik to kindly share the screen in the meantime. Dr. Bhavna, over to you.
Dr. Daraksha, you have covered all the aspects related to the adolescents, and you have mentioned more than 30%, I think, adolescents are उनका जो आपका screen time है, that is would be I think more than 3 hours per day. And the social
Yes,
media
ma'am.
has a I think good or bad effect on their adolescent also. Na? Like social media is also a challenging aspect hai related to the adolescent.
Yes, ma'am.
Otherwise, very good. Oh,
Thank you, ma'am. Thank you so much.
Okay, then I'll request Dr. Glory to do her PPT presentation. It's over to you, Dr. Glory. The screen is all yours. You are still not on slideshow.
Yes, sir. So am I audible?
Yeah, you are audible, but still not on
I'm
slideshow.
I'm putting it on slideshow now. Is it
Yeah,
on slideshow mode?
yeah.
Okay. Good evening, everyone. Thank you, Dr. Chopra, sir, for granting us an opportunity to the young faculties to present the attribute to showcase them in form of this PPT, which was arranged on the World Health Day 2025, having the theme as Healthy Beginnings, Hopeful Futures. I, Dr. Glory Takwale, Assistant Professor, Department of Community Medicine, MGM Medical College and Hospital, Chhatrapati Sambhajinagar, Aurangabad, Maharashtra, will be presenting my topic, which I have titled as The Hand That Rocks the Cradle, which deals with mothers and grandmothers' knowledge, attitude, and practice in effective newborn care. The focus of area being neonatal health. So, as we all know, newborns are the children between 0 to 28 days of birth, and they are a highly vulnerable group to various morbidities and mortalities. The first year of life has the highest risk of death, in that the first 24 to 48 hours has the maximum chance of death, followed by first week of life, then the first month of life, and the first year of life. So the risk of death increases, and it is maximum in the first month of life. The number of deaths are also maximum in the first month of life. Why are these newborns vulnerable? Given to their immature immune system, lack of vaccination protection, dependence on caregivers, high risk conditions like low birth weight, small for date, etc., environmental factors being temperature changes, humidity, exposure to pollutants, etc. So, what can be done to protect these newborns? What we have is essential newborn care. So, under the National Health Mission in the year 2014, the Indian Newborn Action Plan was implemented. It provided a center stage for newborn care, especially through home based care. So, what does essential newborn care include? It includes immediate care at birth, prevention of hypothermia, care of eyes, cord, skin, exclusive breastfeeding, vaccination, care of the sick newborn. Now, how important is newborn care? It is extremely important because it improves health outcomes. It also reduces neonatal mortality, which is evident from the number of deaths, which were 37 deaths per thousand live birth in the year 1990, which was brought down to 17 per thousand deaths per thousand live births. And also, when we consider the numbers, it is 5.2 million deaths in 1992, which has come down to 2.3 million deaths in 2022. However, this decline of 56% is quite slower than the rate of the decline among children under 5 years of age. Now, who provides the newborn care? At birth, we know that the healthcare workers, like the trained attendant, ANM, medical officer. After birth, it is the healthcare workers like the ASHA, ANM, medical officer. But once the baby is home, the caregivers shift and it becomes the mother, grandmother, and the female family members, whom I have called the hand that rocks the cradle. So, what is the role of home caregivers? Mothers. Mothers are the primary caregivers. They are attending to the newborn's immediate needs like feeding, cleaning, bathing, etc. They provide bonding through physical closeness, breastfeeding, and nurturing care. Decision making regarding the baby's feeding methods, vaccination, medical treatment, etc., are also done by the mothers. Grandmothers, they also play a crucial role in childcare in providing practical help, example in bathing, massaging the child. They are a great source of information support to new mothers about newborn care, and they are the ones who pass on the family history and tradition of childcare. There are certain common newborn care practices provided at homes in India. There are good practices like breastfeeding, rooming in, skin to skin contact, warm atmosphere, massaging the baby. But there are also some harmful practices like discarding the colostrum, early bathing, Jan Guti in prelactals, honey is given at when the child is born. Kajal to the newborn eyes, pouring oil in ears, application of cow dung to the cord, overcovering of baby, keeping baby in closed, dark, ill-ventilated room. But there is also changing pattern of the newborn care in India, which is because of increased awareness about healthcare, increased female literacy, increased use of social media, change in family types from decrease in joint or three-generation families to increase in nuclear families. So, based on this background, to summarize, mothers and grandmothers are intimate caregivers of newborns. Their knowledge, attitude, and practices can have significant effect on newborn health. With this background, we aimed to study the mothers and grandmothers' knowledge, attitude, and practice in effective neonatal care in Varud Kazi village near Chhatrapati Sambhajinagar, Aurangabad. It is a village located 10 kilometers away from the district headquarters, and it is also the village adopted for family adoption program for the MBBS undergraduates of the year 2023 to 2024. About the study, it was a descriptive cross-sectional study carried out in the month of January this year, 2025. The consenting mothers with at least one alive child and grandmothers were included in the study. The data collection process, it began with the MBBS students on the day of the FAP visit who went door to door. They collected data from participants in pre-tested questionnaire by face-to-face interview method, followed by educating the participants about the correct newborn care practices. And the data was collected, analyzed, and chi-square test was applied. Now here are some glimpses of the data collection. The team which went to the FAP visit and the students who are collecting data by interview method and interacting with the mothers, grandmothers, and the children. Now coming to our findings. So 221 mothers who were mostly in the age group of 18 to 25 years and 221 grandmothers in the age group of maximum were in the age group of 40 to 45 years who participated in the study. Among them, 97.3% mothers and 54.3% grandmothers had institutional deliveries. Some more pictures of the data collection. Then we assess the correct knowledge about newborn care, which is depicted by this graph. So there is a comparison of correct knowledge of newborn care between mothers and grandmothers. The correct umbilical cord care was, the knowledge about that was more in mothers. The blue color depicts the mothers, green one for the grandmothers. So 85.1% mothers were having the correct knowledge of umbilical cord care as compared to only 20.4% of grandmothers. Bathing time almost after a week. It was the knowledge about that was found very less, and 26% mothers knew it. 6.8 mothers percent grandmothers were knowing about it. Correct eye care was the knowledge about that was found in only 16.3% mothers as compared to 29% grandmothers. Care of baby during illness, it was found, the knowledge about that was found in 82.8% mothers versus 69.6% grandmothers.
8 minutes.
Okay. So may I continue?
Yeah, please, 2 minutes more.
Yes, warm clothing was given. The knowledge about that was found in 81% mothers versus 71% grandmothers. Skin to skin contact, the correct knowledge was identified in 87.3% mothers compared to 60.6% grandmothers. The vaccination practices, I am not able to see the bar graph because of the screen, but I think it's visible to you all. Moreover, when we studied the practices, statistically significant difference was found in between practices of mothers and grandmothers for the care of umbilical cord, newborn bathing time, care during illness, skin-to-skin contact, and vaccination. So we conclude from that this study that the knowledge, attitude, and practice of mothers regarding newborn care are better as compared to grandmothers, which will significantly contribute to better newborn outcomes over the years. We recommend that more IC targeting grandmothers be carried to improve home-based newborn care. The dual benefit of this study was to the community through increased awareness and to the MBBS students who are the Indian medical graduate in making through knowing the perspective of newborn care in rural setting. So I would like to end by saying this beautiful poem, which is in line with the topic, The Hand That Rocks the Cradle. Blessing on the hand of women, angels guard his strength and grace. In the cottage palace hovel, oh, no matter where the place. Wood that never storms assailed it, rainbows ever gently curl. For the hand that rocks the cradle is the hand that rules the world. Infancy's the tender fountain, power me with beauty flow. Mothers first to guide the streamlet, from them souls unresting grow.
10 minutes.
Okay. So let us strengthen this hand together so that a healthy beginning will lead to healthy, hopeful futures. Thank you.
Thank you, Dr. Glory. Over to Dr. Seema for comments.
Very good topic, especially the title was very मतलब बहुत cute title था और ये grandmom की जो study which you have done is really मतलब new to me and it's a new aspect, new research, very well made slides, complete था content, but वही थोड़ा सा time frame कम हो रहा, but it is good effort. Thank you so much, sir.
Kindly stop sharing your screen, Dr. Glory. Over to Dr. Bhavna. You have to unmute yourself. Dr. Bhavna, you have to unmute yourself.
Okay. Thank you, Dr. Glory, for such a comprehensive presentation and comparison between the two generations. Okay.
Thank you,
So,
ma'am. Thank you.
Thank you, Dr. Glory. Again, reminded me of my presentation in 2003 in a national conference where I was talking about newborn care. It was a WHO sponsored session at Belgaum, and where I concluded that the further reduction in the infant mortality will not be possible until unless we reduce the neonatal mortality. So we took around 13 years to come up with India Newborn Action Plan from 2013 to maybe 2014 or so. So India is a huge country where changes they happen, but they happen very slowly. It takes a lot of time. And to implement any new program in India, it takes 5, 6 years time to train and retrain the workers. And yes, it is important. But then the medical colleges can always take the lead in increasing the awareness, and FAP is one of the important tool as far as increasing the awareness of the people are concerned. Ultimately, it is the health of the people in the hand of the people which is important. If people understand this, then majority of diseases can be prevented. And of course, this is a good way to talk about it. My only reservation about this is you should have used the term neonatal care regarding on the newborn care, because then neonatal care is much more neonate is much more apt in comparison to newborn as far as the first 28 days are concerned. So thank you very much. And of course, I also had an acronym, and you can also see that presentation maybe somewhere on my YouTube channel or maybe on the slide share, where I say for happy outcome, you have to apply happy. And happy is again an acronym, which is again, I will not be elaborating on that. If you are able to find out the presentation, you will be able to find out what is the meaning of happy and how happy can be uh, implemented as far as the newborn care is concerned. Thank you very much for your presentation. And now we will be inviting Dr. Kanchan to present her PPT. So over to you, Dr. Kanchan. The screen is all yours now.
Yes, sir. Sir, my PPT is visible.
Yeah,
Is
it
it?
is on.
Yes, sir.
Fine.
Thank you so much, sir. Now, I am Dr. Kanchaninge. I am assistant professor in D.Y. Patel Medical College, Pune. So, my topic of presentation is adolescent mental health, as the adolescents are the foundation of our community and country. So, WHO defines the adolescent as the age between 10 to 19 years, and as per National Youth Policy, it is 13 to 19 years. So why it is important? Because this phase is of transition between the childhood to adolescent, and during this transition, it is a time of rapid physical, cognitive, social, and emotional maturing. And this with this transition, there comes with some problems like nutritional problems, then sexual and reproductive problems like early pregnancy, childbirth, unsafe sex, then sexually transmitting diseases. Then some mental health problems are also common like depression, anxiety, suicidal thoughts, then substance abuse. Then they are also prone for the communicable and non-communicable infections and the road traffic accidents, injuries, and violences. So in this picture, we can see this is very common scenario in our families also, or in our friends. We can see here these are the adults, and they are carrying their own alternate universe in their pockets. And this is the area of digitalization. So digitalization comes with some pros and cons. So the major problem is they affect the mental health. This digitalization affect the mental health of the adolescent. So coming to some key facts, like globally, sorry, sir. Okay, globally, 1 in 7 adolescents experience this mental health disorders, like accounting for 15% of the global burden in this age group. Then depression, anxiety, behavioral disorders are some of the leading causes for the illness and the disability among the adolescent, and suicide is the third leading cause for the death. Now coming to national data, as per National Mental Health Survey 1, it was done in 12 states of India. Around 3.7% of adolescents were suffering from mental health disorders. For state data, the Maharashtra state, it will be covered in second survey, which will be conducted by the experts from BJ Medical College, and this survey will be supported by NIMHANS and MOHFW. Now coming to the impact of this mental health. Now mental health issue have far-reaching consequences. It not only affect individual but also the community. These challenges can disturb the personal well-being, professional productivity, and social relationship. So understanding the impact is crucial for designing the effective intervention to support the mental health at all levels. Now, there are some factors which give rise to mental health, like biological factor, maybe the genetic makeup of the person, or the environmental factors like his environment or the school environment or the family environment, we can say some psychological state or the use of social media, like the influence from the social media, we can say the comparison in the social life, then there are lifestyle, sometimes the financial problems or the global problems like some political situation and all. These all factors may lead to the mental health disorders. So some mental health problems are very common in adolescent, like anxiety disorder. Around 4.4% of adolescent goes through the anxiety. Around 1.3% they are prone for the depressive disorders, and 0.1% they may have the eating disorder during their right phase. And some of the personality disorders like the risky behaviors or the psychosis are very common in the adolescent. Now, when should I be concerned? Like this mental health is a continuum from the healthy to unhealthy. And the problematic behavior are not the proof that the person has mental health problem. That's why the early prevention and the treatment are the vital for the mental health. So we can identify the status of the person with some signs and symptoms like mood swings, like then the loss of interest in the daily activity, or the feeling of anxiety, fear, then lack of focus. They may feel the fatigue, lethargic, or isolation, even in the family or in the friend circle, or change in the sleeping pattern of the person, or there is some unidentified physical pain. So from these symptoms, we can understand the status. One more important factor in mental health is a stigma, because stigma it affects the health seeking behavior of the person. So we need to break this stigma through the proper education. We can spread the awareness, we can reduce the misconception related to the mental health, we can normalize this mental health issue through the open discussion. We can give this proper support, we can encourage the person to seek the help without any judgment, and we can listen and understand their problem without stigma. So this all through this all we can break the stigma related to mental health. Now, where to get the help? So we have professional guidance through therapists, counselors. We have online help, that is through telemedicine. We have mental health organizations. So through proper support and guidance, we can give them hope and strength to seek the proper care. Now, some steps for maintain the healthy mental health. First is self love. So we can make a time for our hobbies or some project. Then we can relax our mind through meditation or doing some exercise, or reduce the use of social media. Like we can prefer the face to face conversation instead of use of any app, or then learn how to deal with the stress. And last, that is to get the help and support when you need it. Now, there are some good initiatives, like Australia passes the social media ban for the children under 16. Then also in Sweden, they have ban on some apps like Facebook's, Instagram, to reduce the violence and crimes in the adolescent age group. Now in India, we also have different initiatives, like for mental health, we have National Mental Health Program. Then we have Telemanas. This is the telemedicine part, which was started after the pandemic. Then we have RKSK that supports the all the factors related to the development of adolescent health. Then we have school health and wellness program. Then adolescent friendly health clinic. We have Kishori Shakti. So this all through this all national health program, we can cover the all the aspects of the mental health, because there is no health without mental health. So the last I want to summarize, like investing in the adolescent health is like a triple dividend. First is health of the adolescent, second is their health during their adulthood, and third is the health for their future generation. So thank you all.
Thank you, Dr. Kanchan, for highlighting a very important issue of mental health in adolescent. And over to Dr. Seema. Seema has been doing a lot of work on mental health, so I think she's the appropriate person to talk about it. Over to you, Dr.
Yes,
Seema.
yes, it was a very comprehensive, very compliment, very complete and good compliment on all the content you have covered in such a short time. Been talking about all the programs, the telemanners app, so many things. So I would like to congratulate for this presentation in the sense ki very informative. I was taking some pics also for adolescent, especially the solutions which you have given is really good. All the best.
Thank you.
Can you please stop sharing your screen? And before I go to Dr. Bhavna for
Yes,
her
sir.
comments, and I'll request uh, Dr. Kirtana to kindly start sharing the screen. And over to you, Dr. Bhavna, for your advice and comments.
Dr. Kanchan, your presentation is very good. PPT बहुत अच्छा था आपका. And you
Thank you,
have
ma'am.
raised neglected जो है ना, mental health is very neglected from all the age groups. It is a neglected aspect, है ना. It is very important for the actual being healthy mental health.
Yes.
And congratulations.
Thank you, ma'am.
Thank you, Dr. Bhavna. Just a, a quick reminder to people that yes, stress is one of the important factor, and if you are interested in knowing how to manage stress, not in adolescent, in all age groups, there is one lecture of mine on stress management. That is non-pharmacological management of stress, which is on their my YouTube channel. So if you will search, you will find that. And with that, we will be going to the next speaker, Dr. Kirtana. Kindly present your PPT. The screen is all
Yes.
yours now.
Is my screen in slideshow, sir?
Yeah.
Yes, thank you, sir. Hello everyone, good evening. I'm Dr. Kirtana. I'm Senior Resident of Community Medicine at Carter Medical College and Hospital, Guntur. Today I'm presenting on the prenatal screening and testing. It is determining genetic disorders, mostly the common genetic disorders like Down syndrome, thalassemias, and other congenital anomalies. It depends primarily on the awareness and acceptance of this test by the antenatal mothers. So, why it should be done? It should be done to determine various genetic abnormalities like Down syndrome, as I already told, and to determine various management during the antenatal period. And also, it helps in improving the outcomes of the conception. Sorry.
Please continue.
Yes. And it is done for all pregnant women and also to those who are having a higher chances of the genetic defects and who are having a congenital deformities of the fetus in their previous conception or in their family members. It also helps in identifying the carriers of the specific genes. And it is done mainly in the preconceptional, it can be done in the preconceptional period and also in the first and second trimesters of the pregnancies. It is most commonly done in the first and second trimesters of the pregnancies. Preconceptional testing is also possible to identify the genetic defects. How it is done is mainly during the pregnancy, both diagnostic and screening tests can be done. First, screening can be done to identify the high risk pregnancies, and a diagnostic test can be done to confirm the pregnancies. Various types of prenatal testings are preconceptional methods, non invasive methods, and invasive methods. First coming to the preconceptional methods, it is firstly family history assessment. By both maternal and paternal side, we can assess the family history and identify any genetic disorders in them. And it also helps leading to genetic counseling by an expert. And it also helps in further genetic testing for any carrier state of either of the parents. The advantages of doing preconceptional methods are to diagnose any type of carrier is present and to counsel genetically the parents even before conception, and to early diagnosis and advice on further treatment and conception, and they can choose various methods of treatments. Coming to the non-invasive techniques, they are becoming popular nowadays. Now they are known as non-invasive preconceptional testing, NIPT. Various techniques are cell-free DNA screening test. It is done by using the maternal blood sample, in which we can identify the fetal DNA particles. From that, the fetal DNA is assessed by a non-invasive method. It can be done as early as at the 10 weeks of pregnancy. It is more accurate than other non-invasive techniques. The second one is serum marker screening tests, which are done to identify alpha fetoprotein and pregnancy associated plasma protein A and other markers. It can be done as early as 10 to 12 weeks of gestation. The next one is the neural tube defect can be tested using the levels of alpha fetoprotein and acetylcholinesterase levels in the amniotic fluid. The other commonly used technique is the ultrasonography. The samples used for testing are mother's blood for fetal DNA and various serum markers.
Daraksha, kindly keep yourself on mute. Dr. Daraksha, kindly keep yourself on mute. Dr. Daraksha, kindly keep yourself on mute. Dr. Daraksha, kindly mute yourself. Somebody should call her and tell her.
सर आप म्यूट कर सकते हो शायद इनको.
Sir, as host, you can mute her.
I'm trying to do it, but it's not coming. I think somebody. Okay, now continue. I hope that she has done it. Sorry for the interruption.
Okay, thanks.
Yeah.
Next, ultrasonography for nuchal translucency. And various serum markers that are tested are alpha fetoprotein, pregnancy-associated plasma protein A, estriol, and human chorionic gonadotrophin, and also inhibin. The advantages of this non-invasive testing are it can be done in as early as first trimester. It can help in prevent pregnancy-associated complications like abortion, small for gestational age, death of a fetus. And coming to the invasive techniques, amniocentesis is one of the most commonly done invasive techniques. It is commonly done in those mothers greater than 35 years of age. It is useful along with chorionic pillar sampling can also be done. It is done as early as in 10 to 12 weeks of gestation. Amniocentesis can be done in the second trimester. Both has a higher risk of having miscarriages and also chance of having needle prick injuries to the fetus also. They are both done by using ultrasound guided needle techniques only. And that one is percutaneous umbilical blood sampling. It is another technique that is done per abdominally using ultrasound guided umbilical blood sampling is taken and the fetal DNA is assessed. And the other technique is pre-implantation genetic testing. It will be useful in case of IVF pregnancies. We can test the genetic pattern of the fetus even before implantation, and we can give proper suggestions and what can be done can be seen. The advantages of these tests are diagnostic. They are diagnostic tests. They help in confirmation of any genetic defects. They are more accurate than a non-invasive test, and they give an insight on the probable outcome. The common adverse effect of this are miscarriages, abortions, infections as they are invasive procedures. They can also cause RH sensitization. Injuries to the fetus can also occur during the procedure, and fetal death can also occur. Coming to the scenario in India, prenatal screening is done to all the pregnant women. Commonly done prenatal screening is ultrasonography. But according to a study done by the obstetric and gynecology department in AIMS Mangalgiri, it showed that 73% has threshold level of acceptability by antenatal mothers to go through prenatal screening. Okay, so we need to bring the awareness of these genetic disorders among the antenatal and mothers, and also in the preconceptional age itself. So various prenatal tests should be offered by the government, and also various policies and programs should be developed. Okay. Last but not least, an Umeed initiative was launched by Government of India, unique methods for the management of inherited disorders. It was done in a selected districts by formation of Nidan Kendras, and also community outreach programs are taken by them. Thank you all. Thank you, sir, for giving me this opportunity.
Thank you, Dr. Kirtana. Accept my apologies for a disturbance in between, but despite that, you were able to complete it confidently. I'll request all the speakers kindly keep yourself on mute and please be careful because you can spoil the presentation of your co-participant. So this should not be happening in the next presentation onwards. So I will now request Dr. Seema to kindly give her comments.
It's again a very good. I'm very happy to say that abhi tak sare all participants are very good in their topics, selection of topics and presentation. But this one especially very beautifully covered all the aspects of need of the art of genetic tracking the genetic disorders. So very good topic taken and very well covered. And the slides were also.
Thank you, ma'am.
Thank you, Dr. Seema. Dr. Bhavna.
Dr. Kirtana, I think, unmute. Your topic is very good. The prenatal diagnosis. Do you have any idea how many of good genetic labs are there in India?
No, ma'am. Actually, in Pune,
Okay, good. No, fine. What's fine?
Anyway, the question is not going to make any difference as far as your marks are concerned. But then, yes, it is important. Yes, it is upcoming thing, and in urban area it is more common because if you want to apply for the whole country, then you have to look into the aspect of availability, right?
Yes.
And then you have to look
Yes.
into the aspect of accessibility also, affordability
Yes.
also. So these are the important aspect, and I'll request Dr. Prashant kindly start sharing your screen because as the next presenter is Dr. Prashant Kumar Bhatnagar. So the screen is all yours, Dr. Prashant. Still, you are not on slideshow mode. Yes, you are on slideshow. So it is over to you, Dr. Prashant.
Thank you, sir. Jai Hind and good evening, respected Chopra sir, jury members, and my dear colleagues. I, Dr. Prashant Kumar Bhatnagar, Associate Professor in the Department of Community Medicine in Gautam Budh Chikitsa Mahavidyalaya and Dr. KKBM Sobharti Hospital, Dehradun, takes the floor to present my presentation on this year's WHO's World Health Day theme. My presentation actually revolves around is there any issue? Can everyone view the presentation?
You can, yeah.
Actually,
It is visible.
I am not able to view the presentation.
You are not able to view the presentation.
I will
You
just
can stop sharing and do it again.
Yeah, I'm just stop sharing and I will try to again share my presentation. I think there's some now everyone can see, sir.
Yeah, please
Okay,
continue.
sorry for that interruption. So my presentation revolves around this year's World Health Day theme. Mainly it focuses on the broad policy aspects of the maternal health and with relevant references to the child health. So we all know that the World Health Day celebrated every year starting from 1950 on 7th of April as the World Health Organization was formed on 7th April 1948, and each year worldwide attention is drawn to a subject of major public health importance, and related to that theme, international, regional, and local events are organized, and it is acknowledged by the various governments and NGOs. So, talking of the World Health Day theme of this year, it is healthy beginnings and hopeful futures. It's the campaign also has certain goals which I will discuss in a bit. So, it says that the health of the mothers and babies is the foundation of healthy families and communities, and it will help ensuring hopeful future for all of us. That means it lays the importance that if we start early in the antenatal period or in the newborn period, we focus on the health, then we will be hopeful for a healthy communities. So just a bird eye view of the last 10-year themes, we can see that major public health importance topics were chosen and an year-long drive on those were organized. So, World Health Day theme 2025 is an year-long campaign on maternal and newborn health, and this campaign will urge the governments and health community to ramp up efforts to end preventable maternal and newborn deaths. It will also help to prioritize women's long-term health and well-being. So, talking of the campaign goals, this year first goal is awareness raising. That means we have to raise awareness about the gaps in maternal and newborn survival. Second, effective investment. We need to advocate for effective investments that improve health of women and babies. So the government should have a political commitment to invest to dedicate their GDP on women and child health. Then encourage support to encourage collective action to support parents as well as health professionals, and then provide information, useful information related to pregnancy, childbirth, and the postnatal period. So the last campaign goal is related to the IEC and BCC. So we need to help every woman and baby survive and thrive. But this task is very critical. Why? Because if we see the WHO global data, each year around 3 lakh women lose their life due to pregnancy or childbirth related complication. Over 2 million babies die in the first month of the life. Another 2 million babies are stillborn. 4 out of 5 countries are off track to meet the SDG targets in improving maternal survival by 2030, and 1 in 3 countries will fail to meet the SDG target for reducing newborn deaths. We have some more challenges like 1 in 5 women experience depression or anxiety during pregnancy or after, but this is something that is not very well addressed. Every 2 minutes, one woman died during the pregnancy or childbirth. Every 14 seconds, a baby dies in their first month of life. There are vast inequalities in where maternal death occurs, as 70% of the deaths occur in the sub-Saharan Africa. Small and sick newborns require special care and attention, and 9 in 10 maternal deaths happen in low and middle income countries. So, the guidance for countries' policymakers is that we have to match the SDG commitment with the investment, the budget that is allocated for MCH. Then we have to invest in all stages of the life. We should follow the life cycle approach. Then we have to make a strategic choices about health priorities and account for the inequities within the country. Because in every country, there are regions where the statistics are poor. There are regions where they are satisfactory. So we have to account for that. We should ensure that local needs or priorities are met, and we have to standardize and improve the data collection using AI tools, you are using digital methods, And yes, because it's a tedious task, so multi-stakeholder, multi-sectoral partnerships are also needed. So the global commitments, I would like to just, everyone knows that SDG goal 3, target 3.1 focuses to reduce MMR less than 70 per lakh live birth and to reduce neonatal mortality to at least as low as 12 per thousand live births. We have initiated a global strategy for women, children, adolescent health 2016 to 30 that aims to end all preventable maternal, newborn, and child deaths. And also the resolution 5 that was passed in the 77th World Health Assembly held in 2024 was adopted, and it also focused on maternal, newborn, and child mortality. And 29 countries adopted that maternal and newborn health acceleration plan, that is also known as 90-90-80-80 targets. That means 90% of pregnant women should receive at least 4 antenatal care visits. 90% of women give birth with a skilled health worker present at the time of birth. 80% of new mothers and their babies receive postnatal care within 2 days of birth. And 80% of the district should have a sick and small newborn care units and emergency obstetric care accessible for at least half of the population. So what roadmap we should follow? We should follow the roadmap that we should first aim to achieve the coverage targets. When we will achieve the coverage target, we will improve maternal and newborn survival and reduce stillbirth. And then we will easily meet the global mortality targets for or SDGs. So talking of the global effort, there is some positivity too. If we can see from this data that maternity service coverage has increased, there is 21% increase in the antenatal care, 25% increase in the skilled birth attendance, and 15% increase in the postnatal care. Talking of the Indian perspective, we all know that MMR has improved and it has gone down to 97 per lakh live birth. IMR has gone down to 28 per thousand live birth, and also the indicators of MCH from National Family Health Service 4 and National Family Health Service 5, we can see there is some improvement in institutional births, there is improvement in postnatal care, there is improvement in antenatal care visits. And moving on to my state, Uttarakhand, and also the district Dehradun, where I am currently, there has been the data is good. The
8 minutes, sir.
Dehradun is having the good as per the national average is concerned. So we have lot of schemes. We have, I will not elaborate everything. Pradhan Mantri Surakshit Matritva Abhiyan, Dakshta, then Lakshya. Similar to Lakshya for child health, we have the Muskan, the quality initiative, then Pradhan Mantri Matru Bandhana Yojana, Surakshit Matritva Ashwasan. Then of course we have JSY, GSSK, we have HBNC and HBYC, and also Mother's Absolute Affection. So to sum up, women need high quality care and we should evolve to manage certain issues. I would like to stress that what we are doing, we are actually offering free normal delivery and cesarean delivery to the underserved population. And every month we are doing 100 to 120 free deliveries. And the best part is that the community mobilization, counseling, and the administration of the scheme is being done by the community medicine department. Similarly, today we have introduced a scheme to prevent the cervical cancer at a very subsidized rate. That is also managed by the community medicine department. So there are certain take-home messages that is important to tell every pregnant woman, and the role of ASHAs, ANM, CHOs are of very prime importance. So I would like to thank all of you for patient listening. Thank you.
For uh, covering the theme of the WHO Day. Uh, I think you are the only one. Maybe someone else will also be covering the theme in greater detail. And thank you also for telling us the initiative which are being taken by your college, because yours is a private college, so I can understand providing free things are very, very tough and difficult. So over to Dr. Seema for your comments.
Very good presentation, Dr. Prashant. There was, I would compliment your clarity of speech and the clarity of contents also. The slides were very much visible. And I understand because the topic is so wide, it is to cover it all in the short time was difficult, but you did it so well. And thank you so much for this presentation, the complete comprehensive analysis of all the World Health Day. All the best.
Thank you, Dr. Seema. I'll request the next speaker, Dr. Sara, to kindly start sharing your screen, and then I'll go to Dr. Bhavna for her comments.
Dr. Prashant, congratulations to summarize the topic within 10 minutes.
Thank you.
Okay, bye-bye. Thank you.
Okay, very crisp and short comments from Dr. Bhavna. And now I'll request Dr. Sara Usmani to kindly do your presentation. The screen is all yours.
So am I audible?
Yeah, you are audible, but I do not know why you have put me on focus.
Oh, sorry, sir. So is it
Yeah,
visible?
yeah, it
So,
is visible.
good evening, everyone. Before I start my presentation, I would like to riddle you all a little. So, do you believe that events that occur during a mother's womb can have a long-lasting impact on a child's health? So, borrowing a little from Mahabharata, do you ever think about it that did Abhimanyu learn about the Chakravyuh when about the Chakravyuh when the scriptures say he actually did? So basically, I don't have the answer to that, but I do have a study which is called the Project Ice Storm, which basically was conducted in Quebec, Canada. And this study tried to study an ice storm as a natural experiment, wherein it was found that after 5 years, the children whose mothers were in the ice storm, they had linguistic, cognitive difficulties, their verbal scores, their motor scores were decreased. And now I would like you all to introduce to the topic of my presentation, that is exploring the invisible barriers to MCH care and the intergenerational impact. The objectives of the slide are to enumerate the invisible barriers. I would also like to elucidate upon how these barriers are strengthened and a few success stories which have really inspired me around the same topic. So what are invisible barriers? So here we have an infographic that I've created. So what are the invisible barriers? These are subtle systemic issues that hinder access, utilization, and quality of MCH care, even when services are available. So the key invisible barriers, they are socio-cultural norms and beliefs, cultural views on childbirth, family planning, power dynamics and gender roles, male-dominated decision-making, limited access to money, transport, organizational and systemic issues, lack of trust and fear, information and communication gaps. So basically here I have put this photo of a hand that is trying to shatter a glass ceiling. So these invisible barriers, which are invisible to the naked eye to us, the public health researchers, but they do hold the people back. They are like an invisible barrier. But this hand signifies the community that when it comes together, we are very strong and we can easily break these barriers together, shattering the glass ceiling. So, borrowing a few from the international events around us, these are events that are happening all around us. These are the events that we read about daily in the newspapers. There is the example of Sudan, where is the rapid Sudan forces widespread uses of sexual violence during Sudan civil war has left lives in tatters. Child malnutrition surges in Gaza as more civilians are killed, and Ukraine has been facing a severe malnutrition problem. So Amnesty International has elaborated upon it as a cycle, which is said of cycle of abuse, wherein pre-terrorism, there are a lot of vulnerable barriers that are already there, and these terrorists strike, and these barriers are so much deepened, and they become so pernicious over time. And after the wars or whatever the terrorism, whatever the wars are fought, what basically happens are the men are mostly, they are decapitated or they are dead, but what is left behind are the very weak women and children who are left, and their suffering is so much prolonged. Again, taking cues from a very well researched historical event, that is the Holocaust, and whose impact has transcended the generation. So on the left hand side, again, I started my presentation with Mahabharata. I would like to quote a line from the Bible right now. The mothers have uneaten the mothers that have eaten unripe grapes and children's teeth are set on the edge. So this is basically a saying from the Bible, which says that mothers who have unhealthy habits like eating unripe grapes, their children have bad teeth. Basically, whatever bad habits or whatever bad circumstances the mother faces, it is always reflected in the children and their health. And not only in their children's health, but in their grandchildren's health, in their great-grandchildren's health. But on the right side, I also have a study which has talked about not only the physical morbidities that are transported beyond generations, but also the resilience. So basically a positive candle in the light of everything negative, that the resilience that these people develop, the Holocaust survivors develop, that is also passed on beyond generations. So basically there was this study that was done in Israel, and they had psychiatric tools, psychometric tools to measure resilience. Again, lessons from India, coming back to India, and I will be elaborating upon two states in India, that is Bihar and Jharkhand. So summarizing a few causes why the Bihar is a state with state with highest malnutrition, poverty and food insecurity, high poverty rates, limited dietary diversity, seasonal hunger due to floods and droughts, poor maternal health, which leads to teenage pregnancies, maternal undernutrition and anemia, weak healthcare systems, which leads to gaps in ICDS and Poshan Abhiyan, gender and caste disparities, girls and marginalized communities are neglected, unequal access to food and care, low education awareness, and population pressure and migration, which leads to very high fertility rates and disrupted service due to seasonal migration. Again, coming back to the state of Jharkhand, tribal health issues are very predominant in the state, which leads to poor access to maternal health services and high maternal and infant mortality in tribal communities. Current challenges in Bihar and Chhattisgarh. Persisting nutritional, current challenges, Bihar, Chhattisgarh, and Jharkhand, persisting nutritional and health inequities, need for targeted interventions in high burden districts. So now here we move on to the part of the presentation where I'll be trying to highlight a few solutions. The few solutions that include the life cycle approach to maternal care. Basically, the life cycle approach tries to ensure equity across all stages of a woman's lifespan, starting from the preconceptional and maternal nutrition to infancy, to early childhood years, to adulthood, to older adulthood. Life cycle approach for maternity care assures equity and elimination of all sorts of barriers, whether they be visible or whether they be invisible. Again, as the presenter before me had elaborated upon the problem of depression and anxiety in antenatal and postnatal women, integrating mental health and MCH care, screening for depression and anxiety, and community-based mental health services which are accessible to all, breaking the barriers of caste and community would ensure that invisible barriers related to MCH care are also targeted. So here in this part of the presentation, I'll be highlighting a few successful case studies. So starting with the example of the people I really look up to, that is Dr. Abhay Bang and Dr. Rani Bang and their Gachiroli model. So as we know, they are the founders of the SEARCH Society for Education, Action, Research in Community Health. So their work has been exceptional. And to give a little background, the Gachiroli district, here I have highlighted in red, the zone that was the Gachiroli district, which is also known as the left-wing corridor. So basically any type of extremism always leads to eruption of MCH services. And the districts that are included are Barshi, Ahmednagar, Nandurbar, Gachiroli initiative, led by doctors Abhay Bang and Rani Bang. The community engagement strategies targeted, which were targeted towards asphyxia management, management of sickness and other unexplained diseases, sepsis management, primary prevention, supportive care in low birth weight. And also their main focus was on training local women as health workers and emphasizing participatory healthcare. Health outcomes of the Gachiroli model, reduction in neonatal mortality and improved maternal health indicators. So basically here is a line regression trend which shows from the year of 1986 to 2006.
8 minutes is over.
Yes. Reduction in IMR points, reduction in IMR 6 points per year was achieved. Scalability and lessons from Gachiroli model was replicated in other regions. Community ownership and equity is the key to success. And coming to the last success story of my slide, which is how Varanasi's 10-point strategy helped reduce malnutrition in 24,000 kids in the last 3 years. So basically, the 10-point strategy included upgrading Anganwadi, improving IFS supplementation, which was all under the gambit of Abhinav Pahel, taking digital measurements for waste, portion tracker, upgrading SNCUs and NBCUs, establishing nutritional gardens, promoting a millet-based diet, and engaging Anganwadi workers and regulating and monitoring and accountability for all the community people present. So basically, I would like to summarize my presentation by saying everyone's healing matters and our future generations are depending on it. Basically, any initiative that is taken with the support of localized community and which is always monitored with scientific gusto will always lead to success, and at the end of the day will lead to erosion of not only visible barriers but also invisible barriers. Thank you.
Thank you, Dr. Sara, for telling us about the invisible barriers which are there in the MCH care. Again, yes, it is important, and happy to see that you have shared two case success stories basically of Dr. Bang and Dr. Rani Bang, which we know from decades. So they are working there. And yes, the public health is all about passion, public health is all about politics, and public health is all about policy. And these three are interrelated. If you are passionate, then you can sensitize the political mindset. And once you are able to sensitize the political mindset, only then the changes will be there. I request all the participants to kindly put yourself on mute, and only then the policy will be formed. And ultimately, it is the politician again, if he has the will, then he will be able to implement it. So these are important things to understand, and these are important things to when you are working in a community, how to achieve what you want to achieve is again that is important to understand. So with these comments, I will hand over the mic to Dr. Seema for her comments.
Thank you, sir. Thank you so much. Again, I congratulate Dr. Sara. इतना massive and इतना sensational emotional content was there, and I was just looking at you, but मेरे को आपकी video नहीं दिख रही. मतलब I was not able to. But very good content. And then there are few things which I would like to comment is that there's a lot of information again. Tried to compile, but the speed was little bit, and we were not able to get everything. It was very interesting. Everything was so good, but thoda sa zyada tha content. So when we are doing this PPT presentation, so that I was really impressed with the thing, the way you have created the scenario. Scenario that is really wide and good. उसके बाद में जो information आपके messages हुए उसमें थोड़ा सा मुझे लगा कि overcrowded हो गई slides, but अच्छा था. Good. Thank you.
So I'll request the next speaker, Dr. Sonam Kushwaha, to kindly start sharing your screen, and I'll go to Dr. Bhavna for her comments.
Dr. Sara, congratulations for a nice presentation in regarding invisible barriers in for maternal and child health. जैसे डॉक्टर your few slides are overcrowded, but rest of the presentation is good.
Okay, then, Dr. Sonam, you are on. Yes, you are sharing. What happened again? Yes. So you are on slideshow. So kindly do your
Sir?
presentation, and yeah. Dr. Bhavna, you want to say something?
हाँ डॉक्टर दरक्षा का भी अनम्यूट नहीं हुआ है, बिटवीन उनका म्यूट.
मैंने उनको अनम्यूट कर दिया है. अब अगर म्यूट कर दिया मैंने, अब फिर वो अपने को अनम्यूट कर लेगी तो फिर प्रॉब्लम है ना? So you can deduct some marks of this kind of behavior. So this is not acceptable. They were told that when someone is presenting, you have to keep yourself mute. So then now it's over to you, Dr. Sonam. The screen is all yours.
Thank you so much, sir. Good evening to all the judges and my audience. Myself, Dr. Sonam Kushwaha, Assistant Professor in the Department of Community Medicine, UPUMS Safei Itawa. I'll be covering the topic under the heading Determinants of Maternal Near-Miss Event among high-risk pregnant women. So beginning with the presentation, I'll be covering the topic under these headings. So first is the definition, then key facts, novelty of the study, aim and objectives, methodology, results, conclusion, and at the end, I'll cover the recommendation of the study finding. So as per the WHO definition, maternal near miss is women who narrowly escapes death but survives a complication during pregnancy, childbirth, or within 42 days of termination of pregnancy. Now moving on to some key facts about maternal mortality. As per the recent data of 2020, every day almost 800 women died from preventable causes of due to pregnancy and childbirth. Almost 95% of all maternal deaths occurred in low and lower middle income countries. And maternal mortality ratio has dropped from in the year 2000 to 2020 by 70% as per the national data, whereas it has dropped 34% as per the global data. Moving on to the novelty of the study. So this study is novel in the sense of population. So previous studies have been conducted among the pregnant women, but in this study, we have included the high-risk pregnant women. As per the study setting is concerned, we have taken the sample from the community, whereas previous studies have taken the sample from the hospital. As per the study type is concerned, so this is the longitudinal study, and the study participants were followed up for a duration of period. Moving on to the aim and objectives. So the aim and objectives were to estimate determinants of maternal near-miss events among high-risk pregnancies, to determine risk factors associated with maternal near-miss events among high-risk pregnancies, and to give recommendations as per the study findings. Moving on to the methodology of the study. So study duration, if we talk about, so this was conducted for the period of 1 year, that is 2023 to 24 April. Study area and population. So all the pregnant women who are registered under high risk pregnancy registered as per the PMSMA, that is Pradhan Mantri Surakshit Matritva Abhiyan, which is being conducted 4 times a month. So as per the criteria, the participants were recruited from the high risk pregnancy registered, and this was data was obtained from the district Etawah of Uttar Pradesh. As per the sample size of the study is concerned, using the formula Z square PQ upon D square, the study sample was calculated to be 180. Sampling technique. For this, purposive sampling was used to recruit the study participants from high-risk pregnancy register. Moving on to the inclusion criteria. So high-risk pregnant women in their 2nd and 3rd trimester of antenatal period were recruited. High-risk pregnant women registered in a high-risk pregnancy register of selected areas were recruited, and women who were registered in high-risk pregnancy register as per PMSMA criteria were included. If we talk about the exclusion criteria, the high-risk pregnant women who were not permanent resident of that particular area were not included, and the subjects who did not consent for the study participation also excluded. Moving on to the sampling technique, a pre-designed, pre-tested structured questionnaire was used, and data was collected at 3 times. 3 visits were done. Firstly, baseline data was collected. Then patients were followed up from the time of at the time of delivery till they got discharged from the hospital, and then they were further followed up at the end of puerperium. Ethical approval was also obtained from the institute. Moving on to the results of the study. So proportion of maternal near-miss events. So as we can see here, out of all the high-risk pregnancies, 13.9% of the maternal near-miss events were reported. And out of those all high-risk pregnancies, majority included eclampsia, that is 36%, followed by followed by use of blood products and postpartum hemorrhage. If we talk about the socio-demographic factors which were found to be significantly associated with maternal near-miss events, these were age groups less than 20 to 25 and more than 25. So the p-value was 0.016. Age at marriage, where we can see that majority were more than 25 years of age, and age at the age when they conceived first time, that is majority being less than 18 years of age. Moving on to the association of maternal near-miss events with the obstetric score. So we found parity to be significantly associated with the maternal near-miss events among the high-risk pregnancies. So high-risk conditions, if we talk about, which were significantly associated with maternal near-miss events. So severe anemia, high blood pressure, elderly primary, and history of previous LACS were found to be significantly associated with maternal near-miss events among high-risk pregnancies. If we talk about the complications, so excessive bleeding per vaginum, convulsion, obstructed labor, rupture of uterus were found to be significantly associated with maternal near-miss events in high-risk pregnancies. So I would like to conclude that this study offers valuable insight into the socio-demographic data of the study participants, their obstetric profiles, the proportion of maternal near-miss events found to be 13%, 14% with severe eclampsia, majority being eclampsia as 36%, followed by severe preeclampsia and postpartum hemorrhage. Diligent prenatal monitoring and timely interventions are necessary to prevent escalation into life-threatening complications. So at the end, I would like to recommend that enhanced access to diagnostic services, community awareness, early screening and diagnosis with prompt treatment is necessary to prevent high-risk pregnancies and maternal near-miss events. With this, I would like to end my presentation. Thank you, everyone. Thank you, sir. Thank you, ma'am.
Thank you, Dr. Sonam, for enlightening us on near miss. And over to Dr. Seema.
So that is really enlightening topic, because these are the days maternal near-miss is a new in for the research topic, or very important topic you have covered. You have spoken so well, or what well spaced content, very good presentation and informative also. This is the way we should teach undergraduate.
Thank you, Dr. Seema. And now I'll request the last speaker, Dr. Surbhi Seth, to kindly start sharing your screen, and over to Dr. Bhavna for her comments.
Dr. Sonam, your presentation is very good.
Thank you.
I think this is your thesis topic.
Yes, ma'am.
It is very nice. Okay.
Okay, Surbhi, so you are on slideshow correctly. So over to you, Dr. Surbhi, for your presentation.
So thank you so much, sir, for this platform to voice our thoughts. And thank you so much, jury, for your patience, and all my fellow panelists as well to be with us till the last presentation. And I'd also like to take a moment to thank my mom who's watching live on YouTube. I was cribbing earlier that, I'm the last speaker because my name starts with SU, but I got to learn so much from everybody else's presentation. So thanks, Ma. Okay. So, this topic that we're celebrating today, talking about today, is healthy beginnings and hopeful futures. And Dr. Prashant has already delved into why we are celebrating this day today. So, World Health Day, happy birthday, WHO. We are kicking off a year-long campaign to urge governments and the health community to ramp up efforts to end preventable maternal and newborn deaths and to prioritize women's longer-term health and well-being, right? And my job has actually been made a lot easier by my previous speakers who have already delved into the various maternal and child health programs that the government has is ongoing. But let's go back a little bit more into history. And as you all know, India was the first country in the world to start a national family welfare program way back in 1952. And after that, the basket of services, the strategies addressing maternal and child health issues have just expanded, be it the universal immunization program, the child survival safe motherhood program, in 1997 when we moved on to reproductive and child health, and in 2005, National Rural Health Mission came about, which was the real game changer. And yeah, I forgot to mention in my introduction, I'm a lead consultant with the National Health System Resource Center, which is a think tank for the Ministry of Health, and we are giving technical support to NHM. So we can't underscore the importance of NHM enough in shaping the country's health systems and how it has brought about an integrated approach to all the various programs that we have ongoing. In 2013, we came up with the RMNCH plus A strategy and various initiatives like RBSK, Rashtriya Bal Swasthya Karyakram, Rashtriya Kishore Swasthya Karyakram, and of course, the government's flagship program, Ayushman Bharat, in 2018. Going forward, again, we've heard about Suman and Muskan from the other participants. And I think Dr. Deepti rightly pointed out that we have actually been missing out on paternal health interventions, though we did have operational guidelines on family participatory care, but that also is a very limited scope. And that's a point well taken, Dr. Deepti, that yes, paternal involvement in our government health programs really needs to be upscaled. So going forward, yes, these interventions have had an impact, right? We see that since 1990, ever since we brought about the CSSM programs, India's maternal mortality ratio has declined at a much faster pace than the global decline, which is of 42%. And it's very heartening to note that 8 states have already attained the SDG target of maternal mortality ratio, which is Kerala, Maharashtra, Telangana, Andhra Pradesh, Tamil Nadu, Jharkhand, Gujarat, and Karnataka. And similar results are witnessed in the impact on child health, where India's decline in under 5 mortality has far surpassed the global decline, and 11 states have also already attained the SDG target of under 5 mortality. We've also had wonderful impact on India's demography with the total fertility rate being achieved at the replacement level of 2. 31 states and UTs have achieved the replacement level, with only 5 still aspiring to reach there. So definitely we have had a lot of good results from these various maternal child health interventions. Now, one of my previous faculty members, she shared this map, World Health Day map, or stamps, sorry, on WhatsApp just a few days before World Health Day. And I was very intrigued to see that 8 World Health Day themes over the last 75 years have focused on maternal and child health, 2025 being the 8th one, right? So we have been, undertaking these interventions on maternal child health, and progress has been made. But are we being too short-sighted? So let me ask you a question. How many of us have seen this series, Adolescents? It's been making headlines, and for all the right reasons. Because I say that it is the crucial piece of the puzzle that is very under-focused. And I think our judge, Bhavna ma'am, was also talking about the implications of social media on mental health. And this series beautifully brings about the importance of nurturing the adolescents that we have. And well, there's one more question that I would like to ask, that if you step into a room and you find that there is water overflowing everywhere, there's a huge mess. So, what is the first thing that you would do? Would you start mopping the floor, or would you actually go and close the tap? I'm sure all of us in our right senses would go and close the tap first, right? But somehow that is not what we're doing today. Let's liken this water that is spilled on the floor to the adults of today, where we have poor maternal child health indicators, there's a high burden of non-communicable diseases and communicable diseases that we are overcoming. And the tap where all this is coming from are the adolescent health issues of yesterday. And therefore, I'm making my case that let's invest in adolescent health today. Why? Again, though I have had some support from my previous speakers, Dr. Darakshan and Dr. Kanchan, who have also, spoken about this topic, but I'd just like to bring some more facts and remind you that whenever we have an anemic, undernourished adolescent girl in our country, she's susceptible to early marriage, teenage pregnancy, multiple childbirths. She's going to lead and give birth to a small, foraged, malnourished newborn who, in the absence of adequate feeding, would be a frequently ill child. And so, this cycle, this vicious cycle, would continue. As rightly pointed out, I think the one takeaway from Dr. Sara's presentation was the impact of generational malnutrition or generational illnesses, right? And also highlighted by Dr. Sonam's research was how adolescent, those women who are, conceiving before 20 years of age, are so susceptible, much susceptible to being a maternal near miss case. So it only underscores the importance of breaking this vicious cycle. Otherwise, we would have continuous issues like vulnerability to gender-based violence, poor sexual health, poor mental health, substance abuse. The weak mothers will get into postpartum hemorrhage, maternal mortality, and neonatal and infant mortality as well, and child mortality later in life. So this vicious cycle has to be broken, and that will be done when we invest in adolescent health. We are living in the widest cohort of adolescents in the world today, with 1.3 billion adolescents. And I would like to again remind our audience that there is a triple dividend, as the UNICEF executive director had quoted, that improving the well-being of today's adolescents, enhancing young people's future prospects, and improving outcomes for generations to come. So there's a triple benefit when we invest in adolescent health. An investment of $1 yields a return of US $5 to $10. Um, and so we have the Rashtriya Kishore Swasthya Karyakram that is ongoing, and there are various strategies under it. There are various focus areas that I'd just like to quickly walk you through.
8 minutes are over.
Okay, so the program focuses on prevalence of malnutrition and IDA among adolescents, and improving knowledge and behavior towards sexual and reproductive health, basically to address teenage pregnancies, addressing their mental health concerns, trying to promote a favorable attitude towards injuries and gender-based violence, prevent substance abuse, and also bring about healthy behaviors to prevent non-communicable diseases. And under the RKSK program, we have a plethora of strategies like the weekly iron folic acid supplementation, the National Deworming Day celebration, the menstrual hygiene scheme, Ayushman Bharat School Health and Wellness Program, and also peer educators, Yuva Samvad, adolescent health clubs. And at the facility level, we have adolescent friendly health clinics, right? So we have strategies, but what about their on-ground implementation? I firmly believe it needs focus. This is still a young program, and as Dr. Harivansh Chopra had mentioned earlier, it takes many years for the programs and policies to actually reach on the ground. And then he was also talking about passion and convincing the policymakers. And here I'm going to go a little the other way around, because when I got to know that this is a competition for faculty members, I was hopeful to make a case and encourage medical colleges to help work towards this theme of adolescent health. So I would urge you all to, take up a cohort of adolescents in your field practice areas, and establish a very health promotive and preventive approach, and document the changes that you see in their health behavior. Please try to generate demand for adolescent health services in your community. Run a model AFHC in your college. You can also train and sensitize interns on dealing with adolescent health issues, and adopt schools in your vicinity, and take up the capacity building of school health ambassadors. You can also support your states and districts by building the capacity of adolescent health counselors in your adolescent friendly health
10 minutes
clinics.
are done, ma'am.
All right, so this is just my last slide, and just want to again stress upon focusing on the women's longer term health and well-being, and investing in adolescent health, because after all, adolescence is a new birth for the higher and more completely human traits are born in this phase. So thank you so much.
Thank you, Dr. Surbhi, and thank you for listening very attentively to all the presenters and taking the key points from their presentations also. So that's an art which very few people uh, have it, and you have to practice a lot to achieve this. And it's a good presentation. Of course, implementation is the basic issue as far as our country is concerned, and a lot needs to be done, and a lot needs to be done, and lots can be achieved only if you are passionate about bringing a change. And this today's event was one of the stimulus for the faculty and other consultants who are working in different areas, so that they get stimulated and they start working in their field practice area, because ultimately, until unless you work in your own field, only then you can bring about certain changes, you can bring about such certain success stories, and those success stories then can further stimulate and motivate others to emulate you, to follow you, or to innovate in them their own strategies in their field practice area. So with this, I will ask Dr. Seema to give her final remarks, and after that we'll go to Dr. Bhavna, and after that we will be live YouTube streaming will be shut off, and then you will have to wait here till I am able to decide the top seven. Okay, so over to Dr. Seema. And I'll request Dr. Bhavna to kindly send me the judgment sheet on my WhatsApp.
That's great, Dr. Sylvie. Good to listen you because you are a spontaneous speaker, and we were very lucky that we listened you in the end because you summarized what everybody has spoken. So that is a skill. I would like to appreciate that, and your content was also very good, very vast, and I'm really impressed with the recommendations which you have given. So that is the enriching experience for all of us to listen. Thank you.
Thank you so much, ma'am. Then my purpose of the presentation is solved if I could stimulate some thoughts
And,
about that. Thank you.
over to you, Dr. Bhavna, for your remarks.
Dr. Surbi, your presentation is very good and your narration is excellent. Your presentation, regarding your presentation. But the implementation for the adolescent health services or the USH, that is a questionable thing. कितना इम्प्लीमेंट हो रहा है उसका जो है adolescents के लिए services, वो एक questionable चीज है. बाकी your narration, your presentation, very nice, very.
Thank you.
Thank you, thank you. Thank you, Dr. Bhavna. With this, we come to the end of this particular segment of our competition by faculty. So, I hope viewers on YouTube have really enjoyed it. So, we'll be shutting off the